Welcome to the Heart of Healthcare podcast. I'm Hallie Tecco.
I'm Michael Esquivel.
And I'm Steve Krause. And every Monday, we bring you the latest in healthcare innovation as we sit down with entrepreneurs and industry experts.
So buckle up and join us as we figure out how to improve healthcare for all. Welcome back, listeners. Today, Michael and I are joined by Dr. Rajaie Batniji, physician, entrepreneur, and advocate for improving healthcare delivery. Rajaie is the co-founder and CEO of Waymark, a company providing tech-enabled community care for people on Medicaid. Previously, he co-founded Collective Health, where he served as chief health officer for 8 years. He was also a clinical assistant professor at Stanford University in medicine, where he trained in internal medicine. Today, we'll be covering value-based care, serving vulnerable populations, potential cuts to federal Medicaid funding, and so much more. Thank you for being here, Rajaie.
It's awesome to be with you, Hallie and Michael.
Oh, thank you so much, Rajaie. Well, it's super excited to have you. So digital health is still relatively young. There are very few entrepreneurs who have scaled one company, let alone two. You come from a clinical background, which is quite rare for a CEO as well. So we would love to hear a little more about your trajectory, what brought you here, and why is it you can't stop?
Well, I can't stop because the problems in healthcare are so abundant. And so I hope that's the reason that all of us get in this and working to make it better. My own path, I trained as a doc. And then during medical school, actually, I left to go do a PhD because I was really interested in how we pay for healthcare, and actually did my PhD in international relations, looking at how we finance healthcare in low-income settings around the world. And then I came back and I thought I was going to, make my dent in the universe by being in academic medicine. And then, realized that I probably wasn't going to be the world's best researcher. And I could have a bigger impact instead of just, writing the papers and putting them out there to influence policy. Could have a bigger impact by, frankly, creating the change that we want to see. And so I started my first company with my partner, Rajaie, back in 2013, Collective Health, which focuses on the employer healthcare space. And obviously, Hallie is on the board there now. And then, for me, my clinical work had always been on Medicaid. I'd worked in free clinics, and my research work was all on how to finance healthcare in low-income settings. And so I think my passion was always there. And then, I just saw that there was this massive opportunity and, frankly, a massive need to make Medicaid work better. And that's why we started Waymark. So I started it with my co-founders, Sanjay Basu and Afia Samoa, to really say, we know what works in Medicaid care delivery. The challenge is that what works has never been done at scale. What works has always been sort of small trials that were grant funded or programs that were funded with seed financing effectively from a health system or health plan. So nobody's ever really created the product for replicating what works in Medicaid. And no one has made that sustainable. And so I said, we have to start a company to do this. Medicaid covers 1 in 4 Americans. These are the folks that frankly need this the most. And yes, it's probably true that investors often say, focus on MA or focus on commercial because that's where the money is. But I think I wanted to disregard that advice and say, let's focus on where the need is. And then the resources will follow once you're proving results. And so I think there's a lot going on, and frankly, still a ton more need to fix Medicaid. And I think we're still in the early days.
Beyond solutions that don't scale in the space, what other specific problems within the Medicaid system is Waymark addressing that just others have not been able to solve?
That's a great question. I think fundamentally, if you step back and you think about the U.S. healthcare system in comparative perspective, what makes us pretty unique is that we don't really have a social care system. Our healthcare system functions as our largest social care system. And so I, as a doctor in medical school, I never learned about how to get access to food for my patients or how to navigate housing. But from a practical perspective, our healthcare system is asked to do that all the time. And so I think one of the fundamental things that we're addressing and the needs that we're addressing is that marriage and, frankly, the enablement of the healthcare system to do what the healthcare system is really good at, which is taking care of people when they're sick, getting them plugged into preventive care to prevent those. But then we're enabling doctors to do what they do best and enabling community health workers and the social safety net to really do their part. And so, what we do at Waymark is we're engaging patients in a community setting. And so we're helping those people that have unmet social needs, those patients that have unmet social needs, get access to stable housing, to access to food. We're helping them get access to transportation so they can make their doctor's appointments. And so we're addressing their social needs and taking that burden for addressing social needs off the healthcare system and then putting it in a place where I think that social care is more effectively and efficiently delivered, which is in the community.
Are we still allowed to use the term social determinants of health?
I've heard it's been replaced by health-related social needs, which is, I think we're going to have to do linguistic gymnastics.
Yeah.
But we actually recently, I won't give too many details other than one of the states that we work in has basically banned the word social determinants of health. And so we have several documents that use that term in the state. And so we just had to do a find and replace to comply with state policy and made it health-related social needs. But yes, it's the same thing. We're just talking about it with different words. And, if you lay that back, right, social determinants of health that are unaddressed lead to health-related social needs. So we're just moving, down the
so absurd.
down the chain, Hallie.
So one area that's related to this as we talk about changes coming is Republican leaders in Congress have directed the House Committee on Energy and Commerce, which oversees Medicare and Medicaid, to come up with $880 billion in cuts for this next budget. As you think about your business at Waymark and think about the impact to the 72 million poor and disabled Americans that benefit from this program, how's this going to impact you all?
Yeah, first, I think it's probably helpful to maybe unpack, what that impact is and maybe think about what are the ways in which the House committee can get there, right? So it's $880 billion over 10 years with costs escalating each year. So it's not quite like $88 billion in year one and then the same amount every year. But for rough math, you can think of it that way. And so I think, there are no specific proposals yet on how they'll get there. But if you think about the budget for the House Committee on Energy and Commerce that's tasked with that cut, the vast majority of their spend, all but $600 billion out of $25 trillion over that 10-year period, is Medicare and Medicaid. And so even if you cut everything else, like nuclear safety and energy policy and airwave management, if you cut that to zero, you're still not even all the way there, right? And you're not going to cut that to zero. So it will, if that mandate will be met, involve, some cuts to Medicare and Medicaid, which, I think will be, challenging. And if you think about where the opportunity for those cuts in Medicaid are, I think the things that have been thrown around as ideas, right, are ideas like introducing work requirements. And I think people are budgeting that to be worth, $100 billion over 10 years. But we know from the Arkansas experiment with work requirements it didn't actually achieve the savings. I can talk more about that. Other ideas that are out there around basically rolling back Medicaid expansion in part or in whole, which is over $500 billion. And Medicaid expansion is what came in with the ACA, where basically, low income adults at, say, income levels of less than 20K, roughly 138% of the federal poverty level, qualified for Medicaid. And so there are ideas that basically shrink who is eligible for Medicaid by either introducing requirements that people work or reducing the eligibility. But I think the challenge with all of those is none of those will fundamentally change the healthcare needs of Americans. And what they do is they'll change the nature in which people who lose coverage get care. We know, it's just hard data, that when people lose their coverage, or then what's going to happen is you're going to use care later in your disease journey, which means it's far more expensive. And so, cutting access to care does not cut the absolute amount of care delivery. What it would do is if you cut that eligibility, as you're basically shifting the burden, the financial burden from the federal government first to the states.
Right.
And the states have to make decisions about what to do. And then if the states do make cuts, then they're shifting that financial burden to the health systems and their providers. And then those health systems and other providers will shift that financial burden to their patients and whoever it is that covers their patients. So you can't really generate savings by cutting eligibility. We know that that's just not the way it works in healthcare. The way you generate savings is you make the actual programs deliver better care,
primary care,
at a lower cost, not just by cutting eligibility. It's sort of like saying we're gonna cut we're gonna measure the efficiency of an engine by how much fuel the engine uses, not how far it actually moves you with that fuel, right? And so you're not going to make healthcare more efficient by cutting eligibility.
Yeah. I think it's worth noting that the KFF team, with their health tracking poll in February, put out the survey results that showed that fewer than 1 in 5 Americans want to see Medicaid funding decrease. And actually, most Americans think funding should stay the same or actually increase. So Medicaid, because most folks know someone who's depended on it, if not themselves sometime in their life, most folks actually support Medicaid. So I wonder how far any cuts would actually get. The work requirement's interesting because that one, I'm curious from your perspective, how that would impact it. Do you think folks who are actually able to work would then work and get coverage through their employer? Or do you think it's just an impossible requirement for a lot of folks that's going to be regressive?
Yeah, I think I always I'm like a historian. That's like what my first study. And I always like, look, none of these ideas are new, right? Like in 2017, the Trump administration wanted to significantly cut Medicaid, and then Republican governors pushed back really hard, right? I mean, the first thing that happens is governors of states are now asked, like, you either cut your program, because remember, Medicaid is a state-federal partnership with the federal government providing funding for the program that's largely administered by the states. So the states are going to push back on it. And so that happened before in 2017, and they didn't go through the cuts. Similarly, work requirements are not a totally new idea. They've been introduced in a few states, Indiana and Arkansas. If you look at the data on what happened when those states introduced work requirements, it's pretty damning for the idea of work requirements. In Arkansas, the Urban Institute did a big study on Arkansas work requirements. I think like 25% of people roughly lost coverage when the state introduced work requirements. And then what they found was there was actually no increase in employment. The whole thesis was we're going to get people to work, and then there was no increase in employment at all. And that's because the people that lost coverage
couldn't work, or because there weren't jobs?
It was some of the people that lost coverage due to work requirements were already doing some work, or they were seeking work. There weren't jobs for them, or they had significant health issues that made it hard for them to maintain steady work. And so what was observed was actually a significant worsening in health outcomes, an increase in burden on the health systems with some uncompensated care, and increased acuity and needs. So it was kind of net bad economically, net bad in terms of health outcomes. And so we can always look back at the data on what happened when's the last time we tried that idea, and ask that question.
In fact, I had read the Kaiser Family Foundation had put out a study in 2019 that showed almost 2/3 of the non-elderly adult Medicaid enrollees were already working full or part-time. So, the full work or the work requirement, it's targeting a smaller subset to begin with, and those that couldn't work or weren't working, the vast majority cited, their illness or disability or caregiving responsibility. So they were, I'm not sure that's going to solve it by itself anyway.
Yeah, I agree. And it's like a small dent in federal spending, and a much bigger, the return that you get for that cut in federal spending is basically increased acuity of needs and more healthcare expenses. So the calculus, the math on that one doesn't line up.
So you're not sleeping well these days, I imagine. There's so much, though, right? Like, even beyond Medicaid potentially changing, there are other policies that disproportionately affect folks on Medicaid. I'm thinking specifically maternal health funding, abortion care access, vaccination programs. We know that it was like almost half of births in the U.S. are to women on Medicaid. So how else, like what other policies are you keeping an eye on that could significantly impact healthcare delivery?
Yeah, of course. I mean, our team does track this regularly so that we can, ensure that we're offering all the resources that we can to our patients, and also that we're staying ahead of where things are going, so we can communicate that appropriately to our patients. So, I mean, you're right that it's not just the funding; it's also some of the rules that may limit access to, for example, we didn't mention like information about vaccination. So, rules limiting vaccination promotion that are emerging. I think there's a long tail of impact that we'll see from, some of the reductions in spend that we'll observe in medical research that will take much longer to develop. I think what we do and what we at Waymark try to bring to the table is like, hey, we're an evidence-based approach, and what we're doing is helping, improve outcomes by actually reducing a lot of the inefficiencies in Medicaid, and by moving care from the clinical and healthcare setting to the community setting where we know that can actually drive those outcome improvements. And so on the one hand, you're right that there's a lot of anxiety. But on the other hand, we know that there's so much opportunity, Hallie, and sometimes, opportunity can come out and be realized in these situations where the pressure is the greatest, right? Where there's so much pressure to do something that's going to generate save, or do something that takes the burden off the health systems. That pressure can generate opportunity for care models like ours that do exactly that. And so I think we always try to, not look at things only through the lens of the challenges that we're facing, but also the opportunities, since I think we're well positioned to really deliver on strategies that meet the moment.
Yeah, Rajaie, one of the things I know that drives it for Waymark will be the underlying tech-enabled platform that you all bring. One of the challenges Hallie and I have encountered, and we've talked about that on this topic on this podcast before, is some of the challenges that tech companies have had in underserved communities. And oftentimes it's been grounded in inequality. So as you think about, in particular, the underserved communities that you are targeting, which is the hallmark of Waymark's business model, how are you going to overcome that?
Yeah, so I mean, there's a lot there. So I'll give a very concrete example. So there's a whole bunch of algorithms that exist for predicting who is going to use care, who's going to spend in the future, right? And so Professor Berkeley Obermeyer published a paper on this like 4 or 5 years ago, which basically showed that there's racial bias that exists in all those algorithms that dramatically underpredicts Black healthcare spending. And the reason for that is if the input to the model is healthcare spending and the output is healthcare spending, but one group of people systematically doesn't have as good of access to healthcare as others, you're going to underpredict their actual health risk if all you're looking at is spend. And so what we did in building, our predictive algorithm, which we call Signal, is base it not on cost, but actually on clinical condition, and brought in all that social determinants data, like who's getting food benefits, what are the zip level social determinants information. And so when you do a condition-based model that incorporates social determinants data, we were able to eliminate that black-white prediction bias that exists in previous models, and also do way better at predicting health risk. So we were able to successfully predict, we had 90% accuracy in anticipating future acute care use, compared to like the next best model, which was about 30%. We published that in Nature, the scientific reports early last year. And since it actually improved on that model, where we're improving the performance based on the outputs that we're generating with our own data. So we continue to reinforce it. And so that's like one concrete example of like within technology, there was pre-built bias, and we can overcome that by building new technology that actually has this population in mind. But I think there's like so much more there. I'll pause there because I don't want to give you like the full list of things.
Yeah.
But everywhere you look, every corner, there's an opportunity that's just like that, Michael.
So you've been talking about this thing you refer to as value veneers, which are essentially fake value-based care arrangements that don't actually change incentives. Can you tell us more about this? I love this term.
Value veneers is really meant to say exactly that, which is like there's this idea that I think is noble in intent, that, basically states will tell their managed care organizations, we want to see more value-based care in Medicaid. And then in turn with that, if you're a good managed care organization, you're like, okay, well, I gotta increase the penetration of value-based care. And so how do you do that? You effectively sign an agreement that might meet like the minimum criteria to check the box on, yes, this is value-based care, right? So we often see this like as a agreement with a health system that effectively puts a de minimis amount of money into a bonus program where if they do, better on cost and quality than last year, they get like a little bonus. And so it checks the box on value-based care, but it's not like the value-based care that like you and I think of when we talk about value-based care, right? It's not that the success of the program determines the financial success of the provider, because it's like a rounding error in terms of the amount of money that's often there. And it's not that the care itself is like fundamentally at risk. And so I think these programs have proliferated as there was more pressure to see value-based care in Medicaid. And so you do see them pretty often. And I think the reason that we called them out as value veneers in a paper I wrote with Will Schrank in Health Affairs Forefront was really that like these aren't like neutral. I think they're net bad for the system. And the reason that they're net bad is they occupy value-based care real estate. And so once like a VBC program is in place, that's like occupied space, and you can't necessarily like assign that provider or those patients very easily to another VBC program. And so, our push is to say, let's do real value-based care. Let's do care that makes net new resources available because we launched the value-based care model. Let's do care that actually changes the nature of care delivery because we launched the value-based care model. And so I think the main kind of mind shift that we've been really pushing for is we should think of value-based care not as an end, but as a means. And it's a means toward new forms of care delivery that we think better match the actual needs. And in our case, in the case of everybody working at Medicaid, we know that the needs are basically social. We know that the needs are community-based. And so let's create and enable teams that can uniquely match those needs. And then that will in turn lead to improved health outcomes, reduction in overall spend. And that's exactly what we've seen when, we implement these programs right.
So they're not baby steps. The value veneers aren't like a way for a provider to kind of get into value-based care. You're saying it's like, it's actually doing the opposite. It's preventing us moving to value-based care because it's taking up this like valuable space and being kind of this check the box, but the wrong box kind of strategy.
Yeah, exactly. And it was good to see that article did get some pickup, although I got invited to speak to like a couple dental conferences because the word veneers was in it. And I was like, I think you didn't actually read the paper.
That's pretty funny.
That is too. So Rajaie, why is there, it seems like there's been more success with VBC in Medicare by contrast. And, I think you've sort of implicitly answered this, but would love to just double click, so what have been the challenges just broadly in VBC and Medicaid? I think your paper mentioned churn as one challenge, but would you mind double clicking a little bit for us on that?
Yeah, absolutely. I mean, there are lots of reasons. I mean, the first is, Medicare is a federal program and it's consistent across states, whereas Medicaid, like we've talked about, is a state program that is partially federally funded. And so it varies from state to state. And so there won't be kind of a uniform model like you can have with Medicare where CMS will roll out a new value-based care model and implement it nationally. You can't really do that in Medicaid, right? So there's state to state variability that makes it hard. You mentioned churn. Your average patient is on a Medicaid plan for probably less than a year. And so that means that a value-based care program needs to generate intra-year success. And so how do you do that? And it's, been harder to do that in a clinical setting. I mean, I'll sort of answer how you do that here as I talk about this. The way you do that is simple. Like my colleagues at Waymark published a a paper in American Journal of Managed Care a couple months ago that showed that 40% of acute care visits in Medicaid could have been avoided with primary care. That's about 3 times what it is, and that's in Medicaid. That's about 3 times what it is in Medicare. And so the way that you solve this on an intra-year challenge is you need to basically focus on those patients that are going to be unnecessarily utilizing acute care because they don't have access to primary care. And that's exactly what our team does. And, we showed that we were able to reduce overall acute care spend or use by overall spend by 23%, but overall acute care use by 23%, avoidable hospitalizations by 40%. We published that in New England Journal of Medicine Catalyst last year. And so you need to have intra-year results, which for most care models are a challenge. I think ours is maybe more uniquely suited to doing that. I think the last challenge is probably like the third rail, but I'll say it anyway, which is a lot of Medicare value-based care can succeed because of the risk adjustment model. And so in Medicaid, you actually have to change care delivery. In Medicaid, to succeed in value-based care, you need to successfully deliver basically, better care at a lower cost. To succeed in Medicare value-based care, you don't have to do that if what you've done instead is capture more revenue through risk adjustment. That opportunity doesn't exist in Medicaid. And so it means that you actually have to be a care delivery company, which we are, to succeed in Medicaid value-based care. And so I think those are to me, the big reasons that make it harder in Medicaid. But I think even though there's variability from state to state, that's something that you can overcome too, right? I mean, no matter where you are, that opportunity, for example, to reduce unnecessary acute care exists, right? No matter where you are, bad policies, for example, we published another paper just last month that our data science and pharmacy team wrote that showed that denials of prescriptions for our own Medicaid patients that we care for increase cost by $600 to over $3,000, depending on the category of drug. Well, we know that if you just don't deny those drugs, you're going to lead to a reduction in cost. So it's these standard interventions that we know work everywhere, even if the programs themselves are configured differently. And so I'm optimistic, actually, that we can solve Medicaid value-based care and make it just as commonplace as we saw in Medicare. It just means we have to focus more on, frankly, care delivery, focus more on resources outside of the healthcare system than we did when we solved this for Medicare, where it was resources within the healthcare system, focus on risk adjustment. It's a just very different calculus.
What advice do you have for founders who want to serve vulnerable populations like the Medicaid population that you guys serve?
I would say my first advice to founders that want to serve vulnerable populations is to do it because it's worth doing. I remember when we were first starting Waymark, I'm definitely not going to name this name, but one of my investors that I'd worked with before told me, if you were doing anything else, I'd write you a blank check, but Medicaid is really hard. Are you sure you want to do that? And so the first step is don't be scared off by the fact that it's Medicaid. Absolutely do not be scared off by the current political environment around Medicaid funding. Some things don't change. And what doesn't change is this is a population that has tremendous needs. These are programs that have tremendous inefficiencies that can be improved. And this is a massive part of our American community, at least 1 in 4 Americans. And so if you can kind of have the time horizon to be patient enough to weather through all that, you can build something enduring, impactful, and I think truly self-sustaining. I mean, there's so much opportunity. So I would say run at it and don't let the naysayers scare you away.
So inspirational. I love the passion. Love it.
One thing I wanted to just touch upon is your personal background. So you were born in the Gaza Strip while you were raised in California. How has your personal background influenced your perspective on healthcare access, health equity in the US and I guess globally?
Yeah, I mean, thank you for asking, Hallie. I mean, look, obviously, I immigrated to the United States as a young child, and I think being from there, we talked earlier about social determinants of health. Everything that you think about when it comes to social determinants or health-related social needs. I mean, it's amplified tremendously. I think my interest in care for the underserved, my interest in basically addressing the determinants of healthcare outcomes that are outside of the healthcare system. Frankly, the energy for that comes in large part from where I'm from. And, I think it's also been inspiring to see people that can hold, moral consistency kind of across the spectrum, right? Like when we talk about, access to care for everybody everywhere, or we talk about, consistent framework for how we think about protecting healthcare delivery. I just want to do the little that I am doing to contribute to just making things a little bit better for people that are suffering tremendously over there. And that's the same spirit that guides kind of the work that we do and the work that I do to make things better for the people that are least advantaged here. And so I see that as a consistent continuum, and I hold myself accountable to being morally and ethically consistent across the board.
Well, thank you for everything that you're doing for healthcare access around the world.
Yes, thank you, Rajaie. Really, really means a lot. Thank you for all you do.
Thanks, Michael. Thanks, Allie.
Thanks for listening to The Heart of Healthcare. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and review, and don't forget to subscribe. The Heart of Healthcare is produced by Hallie Tecco and hosted by Michael Esquivel, Steve Krause, and Hallie Tecco. The show is engineered, edited, and mixed by Kyle Moore. Visit our website, heartofhealthcarepodcast.com, for show notes and details.